Welcome to the Genius Project. Hi, Susan. How are you?
I'm good. How are you tonight?
I'm great. So I'm here with Susan Clinton, and we are starting a brand new podcast. And our goal with this podcast is to have real conversations about difficult subjects in physical therapy practice to get to the heart of what is important in our practice, namely integration. For those who enjoy well-being in life and success in physical therapy, the key ingredient is being able to integrate body and mind, bio and psychosocial, or the yin and the yang, depending on what your philosophy is. In healthcare, we're drowning in information, yet starving for knowledge. So this podcast is a call to action. Collectively, we hope to reframe our treatment of persistent musculoskeletal pain by looking at the whole person as they present to our office within a biopsychosocial framework. We are thrilled that you are joining us as we collectively step into our future as a profession by making the complex simpler. Not simple, but simpler. Every project on this podcast will be a 3-month journey with one podcast each month. In the first month of each project, Susan and I will introduce the topic and look at the challenges that it produces in our clinical practice. In the second month of the project, we will invite a guest lecturer with expertise on the topic to join and increase the depth of our understanding and challenge our biases. The last month of every project will be an invitation to discuss with a handful of people who sign up on a first-come, first-served basis to ask questions of our expert and ourselves to really hone in on the topic and to develop some transferable skills that can be used immediately in the clinic. So if you want to be part of the discussion, sign up and join in for that third month. These podcasts are designed to be a mini class for a variety of topics that present challenges to us collectively as healthcare professionals. Join us as we explore our first topic, and I'm going to let Susan introduce this first topic for us.
Okay. So the title of this project is the Therapeutic Alliance. Does my communication style foster a great therapeutic relationship? And that sounds kind of like a very heady title because there's a lot of fancy words in there. But I love it because there's a couple of things that are very important. And the words that stand out to me are communication, alliance, and relationship. And actually, these are the things that our clients are looking for when they're coming to our practices to find help, for especially if they have persistent pain. As Carolyn talked about, we're going to be talking with a bias towards persistent musculoskeletal. She says skeletal. I say skeletal.
Potato.
America. But we're going to be, looking at that, looking at those people with a different lens other than just the traditional biomechanical lens. There's a place for biomechanics. There certainly is. But what we're going to do is widen that lens through these podcasts, and especially this very first one, and really talk about some things that people have kind of never really had a lot of, not really, I would have to say education in. I think people have heard of it and they know about motivational interviewing a little bit, and they know about, trying to get the patient to talk and tell their story. But in reality, we're all very busy clinicians, and does our communication style actually turn our patients off and interrupt our therapeutic relationship, thus making the alliance with them not very strong? So some of the things we're going to talk about is, some of the things I want you to actually think about as we kind of talk about some of this stuff is, how does your first encounter with your clients look like? Is it by phone? How are they greeted? How are their questions answered? Is there warmth and empathy from the first line greeters for your clients, or is it you? Where is your first encounter as a clinician? Is it the day they walk in the door with all of their paperwork and all of the forms they needed to fill out? So our communication style and physical setup of the clinic can have a significant first impression for your client. So Carolyn, let's dive in, shall we?
Sounds great. So I also want to highlight that our guest speaker for this project is going to be Alison Sim. Mm-hmm. And Alison comes to us from the land down under in Australia. She is a very experienced osteopath who has a lovely handle on the biopsychosocial perspective with some really great skills around motivational interviewing, around cognitive behavioral therapy, and around acceptance and commitment therapy. And so she has a really lovely way of bringing those more psychological skills into a therapeutic relationship as physical therapists or as physical medicine rehab sort of specialists, right? So she will join us next month. And so again, we welcome her to the stage at that point, but we're going to set this discussion up for Allison today. So we're going to talk a little bit about how to build a strong therapeutic alliance. And I love Susan's, sort of highlight of what are the important words in there. Alliance just means a connection with someone. An alliance means a positive connection, a connection that is created for good, really. And one of the things we know is that patients' expectations are actually the strongest predictor of their actual outcome. So if we can understand their expectation, we can create great expectation, we can actually increase compliance. And when we increase compliance, we have positive treatment outcomes, we can promote optimism with patients, and we can increase their hope, which then in turn decreases stress and tension. So one of the first things we're going to talk about over this next maybe 30 or 40 minutes is how to create expectation. We're going to leave it up to Allison to really dig into motivational interviewing for us next month. And she's also going to help us dig into creating value-based goals. So our job this next 30 to 40 minutes, Susan and I are going to talk about what's the art and science of shaping treatment expectation. How do we actually do that? So when we look at that, what we're really trying to do is create an environment for our patient interaction. And the research, if you want to actually look at some work around the social piece with regards to persistent pain, Claire Ashton-James is a researcher in Sydney, Australia. And what she has shown is that our warmth, our mood, and our confidence are actually the three strongest predictors of who's going to develop a strong therapeutic alliance with their patient. But it really all starts with credibility. And credibility happens almost instantaneously when you meet the patient, right? And it needs to be very effortless. So let's talk about what those key kind of parameters are. One of the things we ask patients to do is we ask patients to make therapeutic decisions alongside us. They've already made a therapeutic decision by coming into your office, either on referral of their primary care physician, or maybe a friend has told them that, they have seen you and, you really help them. But patients really have very little expertise on treatment alternatives themselves. What they do have is they need to develop trust. They need to trust that the treatment that you give them is ultimately driven by a clinician who truly cares and is motivated to help. So that's really what it boils down to. There's some research from back in 92, and I can't think of the author off the top of my head, but I certainly can provide the link to it afterwards. And what that research showed was that actually 15% of whether the patient got better or not was only tied to the intervention that was provided. Only 15%. And yet we spend so much time as clinicians learning our wonderful manual skills and interventional skills. And yet we spend very little time looking at the rest of the skill set that needs to be done to really build trust with the patient. So the interesting thing that Dr. Claire Ashton-James talks about, and again, we'll include on the links below after the discussion today, is she talks about clinician trustworthiness is really based on empathy more than competence. So really think about that. Your empathy more than your competence or your clinical skills are going to build that alliance or that ability for your patient to trust you.
I like that. I like that for many reasons. The first thing that dawns on me when this comes up, developing and portraying that warmth and that empathy to patients is, how do you greet them? Are you running from one room to another, and do you look frantic? Are you frazzled? Do you look overworked? Do you have stress in your voice? How's your tone? Or are you actually taking a moment to stop and really greet them, eye to eye, handshake to handshake, calling them, asking them what they want to be called? Hello, Mrs. Smith. What would you prefer me to call you? And let them be able to kind of give you that permission to, if they want to use their first name or if they don't or whatever. But just taking that moment, and it doesn't take much more than a moment, even if you are busy, to stop, take that breath, and really look somebody in the eyes, just to let them know that you see them. You don't just see a patient in front of you, you actually see them.
Excellent. I would agree wholeheartedly.
Mm-hmm.
It's interesting. Again, Dr. Ashton James talks about, age. Sometimes younger therapists think, I can't develop that alliance because I'm young. What she actually has shown in her research is that age, gender, or specialty don't make a difference in therapeutic alliance and in developing empathy. So that's great, because those things we can't modify, right? You can't change your age and gender. Of course, we could have a discussion about that, but that's not an easily changed piece. And certainly our specialty, it's who we are. So what makes clinicians more empathetic and therefore more competent? Well, let's start looking at what is really empathy, and who better to turn to than Brene Brown. So Brene Brown is a social work scholar in Texas, which I think is your home state, Susan.
It is.
And so she's a wonderful researcher, and she really does a nice job in the short little video clip talking about what is the difference between empathy and sympathy. Because what your patients do not want is your sympathy. Sympathy means you're looking down on them, you're pitying them, you're feeling sorry for them, and that does not build a therapeutic alliance, actually. Okay, that actually puts you in an elevated position and your patient below you. So let's watch this for a moment and listen if you're listening instead of just watching, and just let's hear what Brene has to say.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
All right. Okay. So that's really a very simple but interesting take on the difference between empathy and sympathy. And a couple things stick out for me. One is really, if we can understand our patient's perspective, if we can actually, often as clinicians, we jump in And we just want to educate them. We want to inundate them. We want to change their beliefs. But we want to change their beliefs before we even understand their beliefs, right? And if we don't really take the time to understand their perspective, we're not going to be effective in establishing that therapeutic alliance.
I think that's a very important statement that you just made, and I think people are kind of thinking, well, how can I be more empathetic? What are some of the steps that I can do? Well, the first one that I always say is be quiet and listen. Pay attention. Don't write. Don't type things into the computer. Maybe take a few notes, but pay attention. Really pay attention to what they're saying. If you do that, you're going to hear the questions that you need to ask. And you're going to be able to make them feel like their story is worth telling. I think that, I think everybody's familiar with the research that talks about in a primary care physician's office, the patients are interrupted after the first, half of a minute. I'm sure there's a...
I think it's shorter, actually. I think it's 9 seconds, to be honest.
Whatever. So, but the point is like, exactly. I mean, that's even worse, less than 10 seconds. But there's I know what to do. I know how to fix you. And this is what you're going to do. And so that changes the relationship to, I'm in charge and you're not. And in order for people to begin to change their beliefs around their pain, their beliefs around what's going on with them, like Carolyn said, we really need to understand what their beliefs are. And that means we may need to ask them at the end of their long history. One of my favorite things to do is to say, in your heart of hearts, what do you truly believe is going on? And sit back and let them come up with it. Because it's not going to be anything that you ever thought it was going to be.
Yeah.
But it is going to help you understand what their deepest fears are, or what their belief system is, and how anchored to it that they may be.
Absolutely. And I think that's right. I mean, bang on. I would agree with that 100%. I think the other thing we're really afraid to do as physiotherapists is listen to the emotion associated with that, and actually to ask permission to explore the emotion, right? That you hear. And it's when you really, it's almost the white elephant in the room, right? You hear despair, you hear fear. And so it's to actually check out, is this what I'm hearing? And can we explore that a little bit more, right? And that's going to fuel connection. That is what's going to connect you to the patient, which is ultimately what you're trying to do.
Yep. And I think the difference is, when we were listening to the Brene Brown video, is it's very easy as a physical therapist to jump in and say, okay, but, okay, so, okay, let's, and then, try to paint that silver lining. Well, the good news is, and that may or may not be helpful at that time. What may be helpful is, she just showed the video with a guy giving a hug. You don't have to have personal contact to show empathy, but you can acknowledge that they're feeling something at that moment, and just ask them, how does that make you feel? And listen to them when they say, and just, you don't even have to say, I've been there, I understand, any of that. You can just be there with them. Just
what she says at the end, thank you so much for sharing that with me. That really means a lot, right? Just, you don't have to have a solution or an answer, just a connection.
And I think if most of us think back to our personal relationships, when we talk about when we're going through good times or bad times, it's like, don't fix it. Just listen to me.
Right. Yeah. Yeah.
Just want to just get this out.
Right.
And we have trouble in our own personal relationships, with that kind of thing. Because we're just driven culturally to okay, I know how to fix it. And then, of course, then they feel badly, and you feel badly when you didn't take their advice or went the direction, because it wasn't your direction.
Right.
What you really, really wanted was somebody to just sit and listen, and let you have whatever emotions were going to come out. And then you're in a space where you can begin to start making changes. And we need to allow our patients that opportunity to grow that way.
Yeah. And it needs to be, they need to direct those changes. And that's where the value-based goals will come in. And Alison will talk about that a little bit more next month as well. But yeah, I think just giving them the space to own their story and, to just share their story. That's so important, right? So that's one piece. Empathy, developing that ability, that skill set to actually truly listen to your patient without judgment, right? That was the other, and to listen to the emotion that they're sharing. The other piece is what you bring into the room as well, which is your mood. And again, what Dr. Ashton James has shown is that a clinician's interpersonal affect or mood actually explains the most variance in who develops an empathetic relationship and who doesn't. So in other words, a clinician's mood and how happy and confident they appear to be is critical to developing trustworthiness, which again was that goal that we're after in developing this therapeutic alliance, right? So we've actually got up on the screen, if you're watching the video at this point, we've got a TED Talk by Sean Acor, and we'll again put the link at the bottom. It's too long a video really to watch together in this moment. Sean is a very funny, entertaining speaker, and so it's well worth taking the 12 minutes to actually listen to his talk. But he really talks about how we as a society have pushed happiness over the cognitive horizon in our culture, right? And so why have we done that? Because we believe that we need to achieve our goals in order to be happy, right?
Right.
But every time
our success is equated with happiness.
Right.
So every time we have success, then we have to chase more success in order to be happy, because we didn't get happy at the first success.
Right, right. And so instead of celebrating your success, we're making our goals for the next, thing so that we will be happy when we get that. But the problem is research doesn't agree with that, right? Research does not show that that's actually how we are happy. And so if we are moody or we are unhappy, then we are going to negatively affect that therapeutic alliance. So we also have to look inwards. We need to look at our skill set, but also just how do we present ourselves, right? Are we overall happy, confident people? Do we practice what we preach, right? And here's what we preach, right? So this is these techniques actually come directly out of the TED Talk and out of the research specifically. And so Susan already talked a little bit about, what do we do? Are we running around like mad people from patient to patient, and we barely can look our new patient in the eye, give them a firm handshake, greet them by name, and then we're going on to the next piece. Okay, let's start with your history. And so if you're just about to start a new encounter, you only have one chance to make your first impression, right? So it may mean that, okay, maybe you have a habit of every time you start a new encounter with your first patient, the first time you see them, maybe you just go somewhere quiet for 1 minute and take a handful of short or relaxed breaths, not short breaths, but relaxed. I don't like to use the word deep so much because deep can sometimes mean we just work really hard at the breath, but longer breaths, smoother breaths, quieter breaths, and just center ourselves before we then go and make that first impression.
Yes, I think just taking the time to pay attention to your breathing can do it. How am I breathing? Can I change it? Okay, I'm ready. Right. And it's just a readiness thing. And if you think about your ability to connect with people and to work with people, it's almost a bit of a, you need a little readiness before you go into the next relationship. You need to ready yourself to be able to present your best self so that you don't fall into the trap of of bringing any negativity or any other kinds of things that may be happening in your day into that relationship with you. If you think about when you meet a friend that's going to be a really good friend, or you meet, a significant other in your life, there's that piece that goes on, and there's that that best foot forward because you want to be there. And we really need to allow our clients to feel like that's the space we've created for them, that we really want to be there. I even use a technique, it's just a very direct technique sometimes that really helps center me, which is, I'm so glad you're here.
That's lovely. I like that.
And it just gives them permission to be here.
Right.
And that's a welcoming thing. And it doesn't have to, it doesn't have any feelings of any other kind of stuff on there. It just is, it's just a mood. I'm happy. I'm so glad you're here. So one of the things that I love about this, the mindful revolution, and the research behind it is it's 21 days to changing, how you perceive the world and how you work through it. And, the gratitude practice and positive affirmations, they have you for 21 days. I took part in this research. I loved it. I loved every minute of it and every day of it. It was really changing. But for those 21 days, every day you come up with 3 gratitudes or positive affirmations that you can make. Even if it's the sky is blue today. In Pittsburgh, that's a big thing. Sky, that's a big thing. But look, I think the trees are starting to change colors today. This is the fall. It doesn't have to be big, grandiose gestures of gratitude. It can be something as small as, I've got my favorite cup in my hand. That's it. And just acknowledging that. And what the research shows is that the more you do that, you actually change your lens from thinking about what has to be done to thinking about looking for good. So you're not looking for bad all the time or for what's wrong or where the other shoe is going to fall and those kinds of things. Instead, you start looking for and actually expecting positive affirmations and positive and gratitudes to actually come quicker because you're so used to looking for them.
Right. And so it's about changing our own practices. Again, before we can change a patient, if we struggle with moodiness, if we struggle with putting our best foot forward with every patient, then we have to kind of look and say, what can I change in my life? And it's probably not just what's happening in your work environment. Right. It's probably then going back and saying, am I exercising? Do I have a cardiovascular exercise program? Because we can look at the benefits of that from a mood perspective, from a health perspective. And if we're asking our patients to do it, maybe we should be doing it ourselves. So again, it's a bit of reflection. What am I doing to take care of myself? And when I take good care of myself, then I can also help my patients to take care of themselves.
Yes. Self-care is not optional. You need to have something in the tank in order to move forward and work with others. There needs to be enough for you in the tank to be able to do that. You can't give it all away and then try to recoup it yourself at some other point in time. You have to fill up your tank first before you can move forward with it. The other piece, and I think the cardiovascular exercise and the research is amazing on this, but it doesn't take a lot. Just even a nice walk can alter mood, can really alter mood. And I would even say just venturing outside for 5 minutes, can do it as well. And the mindfulness or meditation is also important. And you don't have to get into a deep state of meditation. But again, I think we can take it back to that short-term strategy of breathing.
Yeah, let's go here. There you go.
Yeah, for that 2 minutes, if we could just pay attention to our breathing, something different, not think the thoughts we're thinking, but pay attention to our breathing, pay attention to maybe our heart rate, pay attention to how I just feel in the moment. Eric Franklin's one of my favorite ones about that. He calls it consumer comparison. How did I feel when I got in this morning? How do I feel now? What can I do to change how I feel now? Right? Because I don't want to feel me all day. I want to feel superior. What can I do to change that? And this is a great slide. I love this because if the human brain were a computer, it could perform 38,000 trillion operations per second. That's a lot of energy. And maybe we need to unplug for a minute. I think that's really good. Hit the reset button. We get caught in our own thoughts, and oftentimes that can drive other things and take us away from our true purpose at the moment. And so being able to take that time, take that breath, take that mindful moment can mean the world to your next thing. Another technique that somebody had taught me a long time ago too was tell yourself the following before you go in, because I was at one point in my practice, because of some things going on in my own life, I was struggling and needed to do some changes for myself. And she told me, she said, before you go into that room, think of 3 things that you're excited about listening to from that patient. Rather than, oh, here we go.
Right. This is a difficult encounter. I know it's going to be hard.
I'm excited to hear about this. I want to hear about this, and I'm looking forward to this.
Right.
And by making so that takes us all the way back to that beginning thing when you were talking, Carolyn, about expectations.
Mm-hmm.
We need to change our expectations as well, not just our patients. They have their expectations, but so do you. So do I. So does everybody out there. And expectations are huge. And sometimes we don't realize how our expectations can get layered onto somebody because it's all done with good intentions, right?
Absolutely. And, so the other thing too is if you find yourself struggling with mood and if you find yourself exhausted at the end of the day, my other question is, and I don't practice what I preach, but I do have good energy at the end of the day. Although I'm also finding that as I get older, that's probably not quite as true as it was 10 years ago. But do we take lunch?
Yeah.
Do we take time for ourselves in the day, or do we just go nonstop for 9, 10, 11 hours? And, physiotherapists, physical therapists, we work hard and we give a lot throughout the day. And if you're going home feeling depleted, you need to start to look at, how do I change that piece for myself, but also for my patient relationships, because that will make a world of difference.
Yes. I tell people when I teach all the time that don't ever let your patients say this to you. Oh, honey, it's okay. Sit and finish your lunch. I'll wait a few minutes. You should be having that time for yourself and taking it and making sure that you're taking care of yourself.
Yeah.
Super important. And your productivity level, believe it or not, will soar because you're putting something in the tank and you're going to be able to think better. If you're not eating, and we were talking about the neuroimmune response, 95% of the serotonin that the brain needs for good decisions and happiness and mood is manufactured in the gut. So if you're not fueling yourself the right way, how can you expect to, get the happy juice pumped upstairs?
Right. And you may not have a chance again to reestablish that connection. It happens so quickly with patients. So that first encounter needs to really be a thoughtful encounter and a well sort of prepared for encounter. And that might be food, it might be breathing, it might just be, I know if we're running behind, you don't want to take an extra 60 to 90 seconds, but take that moment because now you're going to have a good interaction with your patient. It's so important. So the other things that, we really need to talk about is how you present yourself with confidence, right? And so the first thing that speaks confidence to a patient is your handshake. And, I'm married to a retired police officer, and his goal in life always has been to have a dominant handshake because that was his role in his work environment. And so he will very much, if you shake his hand, it'll be a powerful shake, and he will actually try and turn his hand on top of yours, right? So I'm going to suggest that in our environment that's probably not what you're looking for. You're not looking for dominance, but neither are you looking for a weak handshake. Your handshake needs to be firm. That makes such a first impression for patients. And if you're not sure, go shake a bunch of your friends' hands and ask for some feedback. Is that a firm handshake? You don't want to be squeezing their bones to death. On the other hand, you want to have that confidence that I'm here, I'm happy to meet you, please come back with me. I mean, it's really just this, constant message through every eye contact. Susan talked about that, your handshake, your appearance. How does that relate to the confidence that you're building with your patient?
Yes, and to make a note about appearance, you don't need to wear white jackets and ties and, perfectly tailored, female jackets and those types of things. You just need to be clean and neat. You just clean and neat just spells that I care enough about myself, but I also care enough about you that, that I'm going to be here and I'm not going to be with one half of my shirt hanging out and, my sock, rolled down over my shoe a little bit. And I'm not trying to judge because I know we're all busy, but it doesn't take a lot to tuck your shirt in a little bit, brush your hair. You don't have to have beautiful hair and beautiful clothes, but you need to have clean, neat, stuff to put on. And if you're wearing, if you're in one of the clinical settings where you're wearing, uniform scrubs or those things, they can still look as nice and neat as you would like to make them.
Right.
I've been in many, many, many healthcare facilities with many kinds of healthcare people from people wearing pink lions on their shirts to people wearing, just a nice tuck-in shirt, or, even people wearing like, loose-fitting clothes. But that, when somebody just didn't take the time to care enough about you to, just get themselves together to come to work that day.
Agreed. I certainly didn't pick this picture of this gentleman because he wore a suit and a tie, but because he looks confident, right? And so I would agree with Susan. I mean, I don't get that dressy for work. I'm comfortable, but I'm very professional and, again, clean, neat, and a reflection that we care for ourselves. Therefore, we can care for you. We can care with you, right? Excellent. Okay. So this is what Susan was talking a little bit about. What are the questions we use to create expectations? So I'm going to let her run with this one.
Yeah. So, here's the earlier slide said those 5 questions that you need to ask. Like we said, Allison will be talking to us about the other pieces that this whole project number 1 is going to encompass. But this is just some groundwork for you to think about that can actually help drive some change in your own behaviors right away into your work. And these are easy things to do. You're already asking questions of your clients. Maybe you just need to change the questions you're asking. So it's natural to ask questions, but maybe we need to be a little bit more mindful about the questions we're asking. I've already talked a little bit about what do you really think is going on. That's the way I ask it. But another way is, what do you think is causing your pain? You need to really know how rooted they are in their belief systems, and because that's going to help you understand maybe which resources you want to send home with them to help them begin to start to change how they're thinking around their pain and what's going on. I love this next one because this is one that clients love to throw back at us. What will it take to get better? And most of the time, their first knee-jerk reaction is, you tell me, you're the therapist. And it's like, well, no, I actually asked you to think about it in a different way. What do you think? What has worked for you in the past? What do you think it's going to take for you to get better? And so they have to kind of, now they can start relating to, well, did something work in the past? Well, I had this and this and this. Did that work? Well, no, not really. Well, what do you think it'll take? So you can get them to, then they can tell their story and talk about what their expectations are a little bit more. Go ahead. I
was just going to say, I think we're so quick to just start giving advice, right? Yeah. To reconstruct their beliefs and to change them. But unless you deconstruct their beliefs, you can't reconstruct them, especially when people are really kind of mired deeply in kind of their belief system, right? So that it's going to take time, and often we don't give that enough time.
Right. And that doesn't mean that you can't start moving through with them, because these next questions set it up really nice. What can I do to help you? What's going to happen? What do you need? What can I do to help you? And let them kind of, again, they may, in a knee-jerk reaction, say what they're, customized to saying, because remember, most of their healthcare alliances have been, dominant, sage on the stage rather than, taking the journey with them. So it may take them a little bit to do that, but they'll come up with something and just jump on that and say, okay, that's great. What can you do to help yourself? Another way to ask this question is, how much time can you give for this? When can you give it? When is it going to be? When in your day can you work on some of this? And let them figure this out. Rather than saying, I want you to do this exercise 3 times a day for blah, 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 da, 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 and then this one and this one and this one. Flip that sheet around and take a look at it and go, oh, would I really, really, really ever do this? And maybe because you're a busy person, so you know how they're going to feel. And so sometimes I've had patients say to me, I can do 5 minutes at night before bed. Fine. Fantastic. We're in. And they're always surprised that I agree with them. Mm-hmm. Because they'll come back the next week and say, well, I actually did it a little more than the 5 minutes. And it's like, it's fine, but they chose to do it. I didn't say, Right. So I just go with what they say. Just go with it. You'll be surprised at how much that will start to change, because you actually gave them permission to say what's important to them. And then the final one, how hopeful are you that you can be better? And you can ask it, how confident are you that you can change? There's probably 1,000 different ways to do it, but the key word here is hopeful. Because I think a lot of them really want to be hopeful, but they have forgotten how to be hopeful because they just haven't had the opportunity to explore that because they've been listening and thinking thoughts around their pain all the time rather than thoughts around what makes them happy. And so they've kind of lost that hope a little bit. Unless my pain goes away, I can never be hopeful again. You know, it could be kind of one kind of diatribe that they might use. You know, because some of them will be, well, as soon as my pain goes away, I'll be as happy as I want to be and as hopeful as I can be. Okay, but how hopeful are you that you right now can get better? You know?
And, you know, I think a lot of that reflects as well as to the diagnoses they've been given, the biomechanical explanations they've been given. So often we have to recognize as a healthcare sort of profession collectively that we have taken hope away by giving them diagnoses that can't change or seem impossible to change, right? So
it scared them.
We've created a nocebo. We've created a negative expectation, right? And so one of the things that we really want to do through this podcast is to really look at our collective competence, right? Our collective competence as healthcare professionals, not even just physiotherapists, and really make sure that we are, you know, sort of talking consistently in a way that reflects accurately what we now know about pain, which is that persistent pain often has very little to do with biomechanical dysfunction, right? And so we have to look at it as a big person or a whole person event or perspective.
Right. Absolutely. And I think being able to give the people the space to talk and tell their story. And these questions right here, if you look at them, what we're doing with these types of questions, you're still asking great questions because you're getting wonderful information. That last one tells me not only how hopeful or unhelpful they are, but you know, kind of a little bit more about the readiness to change and what do I need to do to kind of maybe help them feel better about changing. You know, it may be another resource or a different link that I'll give them if they, you know, are very unhelpful versus somebody who's like, I'm here because I know this is going to make a difference. Right. You know, I have expectations. I've heard about you. I want to be here. You know, I'm all in. You know, we have a, you know, a whole, you know, scale of responses that can occur here. Yeah. But what you're doing here with all of these is you're turning the locus of control away from you back to them.
Absolutely.
And that's where it needs to be. They need to be driving the ship or you know, flying the plane or, you know, driving the train, whatever one you want to do. Yeah. It's them. This is their humanity. This is their humanity with all of its complexity that comes with it. And all we're doing here is honoring that around the constructs of what they're coming in to see us for, which is for, like we talked about, you know, this whole project is about the complex, persistent pain person.
Absolutely. It's almost like a big ship that comes into a harbor where, you know, a pilot or a guide, like an assistant sort of, there's probably a word for it, I can't think of it, but someone actually comes on board to help them just guide into the harbor, right? But the captain is still driving the ship. The guide comes on because he knows the harbor, right? So they are still the captain of their ship. We are just that pilot guide that comes on for a short period of time to help them negotiate the harbor. Yep. Right? And get to the goals that they again want to achieve. They're not our goals, it's their goals. And that's something right there. And goals that have value to them are important to them. That's the other piece we need to
No, I should goals. No, I know I need to goals.
Right.
There's enough should-haves and need tos in our life. What do you want?
Right.
What do you really, really want?
Right.
It's like asking somebody what kind of music they like. Because what they like may not be what I like. And that's just fine. But I really don't want to listen to their music. Maybe I want to listen to my music. And so it's just, you know, it's as personal as that. And it's really a good way to just get them to begin to understand that, oh, I've never had anybody do this with me before like this. what's this all about?
Yeah. And it is a unique experience. When you do it and you do it well, patients will gravitate to you and say, wow, that is a very different interview than I've ever had before. Or I really feel like you heard me and listened to me. Thank you very much.
Or nobody talked to me like this about my stuff before.
Right.
And I think everybody out there, I'm going to give you a big shout out because you're part of the way there. Because I know for a fact your patients all say to you, maybe not until the second or third or fourth visit, and that's okay. They don't do that for me either. But they all say to you, you're kind of like a psychiatrist or a psychologist as long as being a physio too, right? And why? Because you're listening to them.
Right.
More and more is coming out because we spend more time with our patients than probably anybody else. Or for the most part, many of our counterparts in healthcare. Right. We have that luxury, that ability. And, it's wonderful because you're already doing it. This is just a way to get into it earlier and to really set the stage for them being the captains of their ship.
Right. And you're doing a good job when you're talking less and you're listening more, right? Mm-hmm. We were given 2 ears and 1 mouth. We should listen twice as much as we talk. It's their story. It's their hour that they're spending with us. And we should really be that guide, right? We shouldn't be the star of that show.
Absolutely. And I think most of the people out there who know me know I'm a talker. So it has been a real paradigm shift for me over the last several years to really sit back and just let this unfold. I wasn't raised that way. I was raised in a family of fixers and, just all of it. But I'll tell you, it makes a huge difference. It really, really, really does. And some of the stuff I can get to that's important to them are such game changers that the rest actually begins to flow so much easier. And it's good. It also sets you up to understand that, which is a real important point when we get back to self-care, is that you're not going to be it for everybody.
Right.
But you will be treating people in such a way as they've never been asked or questioned or understood before. You may still not be the person that is going to finally do it for them. They may need somebody else. It's okay, because not everybody's going to strum everybody's central nervous system. But you'll learn right away, how to find out who you need to refer and who you need to refer to, maybe even a little bit quicker, which is kind of nice.
And they will be huge fans for you having listened, connected with them, and then directed them in the direction that they need to go to. That is not a loss. That's a win. Right?
Yeah, absolutely. Yeah. Totally a win. Totally a win, because not only did you listen to them, but you listened and acted in a selfless way for them. Mm-hmm. That it's not selfless on our part. We know that, but they don't. Right. They see that you have said to them, you belong here and I'm going to help you get there.
Right. Right.
And this is one of the things I can do is let's get you to the right person or the right thing that can handle this part of it as we move forward or whatever it may be. Yeah. But it's good stuff. And but that's part of the self-care is you're not going to be everybody's healer, but you will be able to direct people to the places that they need to go. Right. And they will be forever grateful to you for that. And because I can tell you for a fact that this is true, I've had and talked to many therapists who are like, oh, I just feel so bad. I wish I had known this years ago, all those patients and blah, blah, the story. Mm-hmm. We all feel like we want to call back for our old patients and say, hey, I know something new. Come on back.
Right.
But I can tell you as somebody who sees somebody who's been around the block several times, I'll ask them, that thing about how hopeful are you going to get to be, and what can I do to help you? And how hopeful are you going to be helpful are you that you can be better? Many, many times I hear the story of the therapist who spent a lot of time with them and listened to them and did their utmost best for them. And then they said, I just wasn't making any progress. It was time to take a break. But they said one thing to me. They said, we'll always be here. If it's not me, somebody, but we'll all be here. When you're ready, come on back.
Right.
And they'll say to me, I'm back.
Right. Yeah.
And it was because of that person
who set the stage, right?
Yeah,
who set the stage
with me. It was because of that person.
Right. With a strong therapeutic alliance. So that's, again, where it starts. And it ends sometimes. But if it can start there, then it will build the relationship in the direction that is going to be helpful for your patient, but also more enjoyable for you, less stressful, right? When you develop those strong therapeutic alliances, you go home feeling better about what you did that day, which is really powerful.
I think there was a great Facebook post by, or maybe it was Twitter, by our colleague Sandy Hilton over at Entropy Physiotherapy and Wellness. And the post was it was beautiful. She said, I spent the day unscaring people. I loved it. It was that's it.
Yeah.
Right there.
Don't be the threat that your patient protects against, right? Their nervous system protects against, right? That's another Sandyism, right? Which is great. Yeah. Yep. So we're going to just wrap up with just kind of a thought around starting to challenge your own perceptions, your own beliefs, your own ability to be creative in this world. And here's a neuroscientist by the name of Dr. Bo Lotto. He wrote a book called Deviate, and he talks about the challenges that we have actually with uncertainty. We don't, as a human species, we hate uncertainty, right? That is the most scary place to live. And so when we're talking about actually moving through this process of chronic musculoskeletal pain and looking at a whole person perspective and taking a biopsychosocial perspective, talking about emotions and unpacking emotions with patients, that really scares us. That really can be a challenging place to be. And so I would really encourage you to watch this YouTube video. Again, we'll leave the link below, and spend some time reflecting on what is your space of possibility. You know, every time we finish, one of the things we want to ask you is what is your next step? Based on the things you've learned today, what is one thing that you can do differently than you're not doing right now that will then go on to build stronger therapeutic relationships with your patients, which is then going to then go on to really helping you to be the healer that you want to be, right? To help your patient on their journey. So what is your space of possibility? That's a question.
And what is your next step? And I love this.
Yeah.
And why? And the video is so eloquent about this. Is change is made in steps. It's not made in big lumps and big movements. It's made real
one
change
step at a time.
Small steps. Yeah. And consistently kind of realizing that you have a next step and the thing to do. And he does such a beautiful job of this. It's just amazing. So I encourage everybody to listen to that and listen to the one thing. What are the small steps? Because you don't have to do all 5 things that the Mindful Revolution says. I mean, unless you're just going to be all in for 21 days and want to do that, start with one. Pick one that resonates with you. Not what resonates with Susan or Carolyn or anybody else, but resonates with you, and work on that one. And then see what begins to happen. Because you'll start looking for the next step. It's natural to start doing that. But if you try to do everything all at once, it's overwhelming.
Absolutely. So what is your next step? We both want you to think about that, to contemplate that. We hope that you'll join us again in a month's time to talk to Allison Sim, and she'll bring us some more expertise and knowledge around motivational interviewing and value-based goals. And then we hope again you join us in December to actually have a real live conversation with Allison and with the people who join us to really sort of break this down further and talk about how does this really work in clinical practice? How do we make it work?
Yep, I can't tell you how excited I am. I'm very excited for next month to actually meet Allison in person. Carolyn's had the opportunity and knows her. I have not, but I've seen a lot of her work, and I'm a huge fan. So I'm very, very excited. And, I think what would be fun is if on the, underneath there's, on YouTube where this is going to be housed, there's comment sections. Leave us your thoughts on what your steps are going to be.
That would be great.
Just get everybody kind of starting to buzz about that just a little bit.
And if we commit to what our next step is, we're much more likely to do it. So good luck with that. Have a great month, and we'll chat next month.
Okay, Carolyn,
Bye
have a
for
great
now.
October, and we'll see you in November.
Sounds great. Happy fall.